So now I'm very delighted to welcome all of you to our last session, which is entitled Research and Funding Needs to Increase Knowledge Generation and Improve Maternal Health Outcomes. And we have really gone on a very deep journey together throughout the 2 days. And in this panel, we're really going to look with our telescopes to the future. How do we advance this whole area of maternal health equity? And the purpose of this panel is to provide us with some of those guidelines. What are the steps that we want to pursue? How do we further our understanding of this issue? And how do we really achieve the outcomes that we're all so committed to? So it gives me great pleasure to introduce to you our first speaker, Dr. Juanita Chinn, who's a sociologist and a demographer at the Eunice Kennedy Shriver National Institute of Child Health and Human Development. And Dr. Chinn directs several programs there: the demography of health, the demography of health disparities, human morbidity and mortality, and population composition. She also co-chairs the Institute's Maternal Health Coordinating Committee and serves on the Trans NIH Unite initiative to identify and address structural racism. So please welcome Dr. Chinn to this wonderful table. Dr. Chinn?
Thank you. Today, I will give a brief overview of NIH-supported research findings and opportunities regarding maternal morbidity and mortality. Next slide, please. April of this year, the National Center for Health Statistics published the most recent official statistics for U.S. maternal mortality. There were 20.1 maternal deaths per 100,000 live births in 2019. This was a statistically significant increase from the 17.4 deaths per 100,000 live births in 2018. As was the case in the 2018 data, Black people continue to be disproportionately impacted. Next slide. These are the rates of pregnancy-related deaths by race and ethnicity in the United States, using the most recent pooled data for 2014 to 2017. The data includes statistics for American Indian and Alaska Native individuals. We see that Black and Indigenous people continue to carry the burden of maternal mortality in the United States. The data for Asians and Pacific Islanders are aggregated. What we know about infant mortality in the Native Hawaiian and Pacific Islanders suggests that this population is also disproportionately impacted by maternal mortality, and thus underscores the need for disaggregated data. Next slide. This slide shows the CDC data on leading causes of pregnancy-related deaths. The leading causes of deaths for all birthing people, including cardiovascular conditions, infections or sepsis, cardiomyopathy, and hemorrhage. Next slide. NIH-supported researcher Dr. Marian McDormand and colleagues have analyzed the literal cause of death data, that is the literal text found in the death record, to identify potential missed or misclassification in coding of maternal deaths. Next slide. Their findings show that first, Black-white maternal mortality disparities may be even larger than what has been reported. Second, that excess maternal deaths for Black people are concentrated in just a few clinical causes of death, including eclampsia, preeclampsia, postpartum cardiomyopathy, and complications of obstetric surgery. Additionally, just a few causes contribute to a large percentage of the Black-white disparity. Next slide. In fact, Dr. McDormand's work shows that more than half of the Black-white disparity in maternal mortality is attributable to just 4 causes of death. They are eclampsia, preeclampsia, postpartum cardiomyopathy, obstetric embolism, and ectopic pregnancy. Next slide, please. Severe maternal morbidity provides a window of intervention opportunities for maternal mortality. Analyzing data from California, a state that has experienced declines in adverse maternal outcomes, NIH-supported researchers, Dr. Stephanie Leonard and team, have shown that racial and ethnic disparities in severe maternal morbidity have both persisted and increased. Known risk factors for severe maternal morbidity do not fully account for increases in disparities, nor do the changes in the prevalence of these risk factors fully account for the changes in severe maternal morbidity and ultimately mortality. If these factors do not fully account for the changes observed in severe maternal morbidity rates, then researchers must also examine non-clinical factors as well. Next slide, please. Access to quality care is critically important. Using data from New York City, NIH-supported research conducted by Dr. Elizabeth Howell and colleagues has shown that people from racial and ethnic minority groups give birth in hospitals with lower overall quality and higher rates of severe maternal morbidity. Black and Latina people giving birth in low-performing hospitals report poor patient-provider communication and difficulties in obtaining prenatal and postpartum care. Next slide. Dr. Mae Wallace and colleagues have shown that in Louisiana, the risk of death during pregnancy and up to 1 year postpartum due to any cause, and in particular, death due to obstetric causes, was significantly elevated among people residing in maternity care deserts compared to people in areas with greater access. A large racial inequity in risk persisted above and beyond differences in geographic access to maternity care. Next slide, please. Continuing with pregnancy-associated deaths, in the state of Louisiana, there are 12.9 homicide deaths for every 100,000 people who were pregnant or postpartum. In fact, homicide accounts for more deaths of pregnant and postpartum people than any single obstetric cause. Next slide. Pregnancy and postpartum period are particularly vulnerable times. Pregnancy increases risk of homicide among women, especially young women. NIH-supported researchers show, using data from Louisiana, that the risk of homicide is doubled for women and girls during pregnancy and the postpartum period. In fact, it is highest in women and girls aged 10 to 29. Nationally, pregnancy-associated homicide is 3 times higher for non-Hispanic Blacks than for non-Hispanic whites. These findings are supported by and grounded in a well-established literature showing that violence against women increases during pregnancy. Next slide. Very recent and timely research from Dr. Rachel Hardiman looking at structural racism operationalized as police violence and its impacts on health, working through a stress model. Dr. Hardiman showed that pregnant people in and around Minneapolis, after high-profile shootings, found that over half of the women in the study answered yes when asked, "Do you feel like this is impacting your current pregnancy?" Nearly 60% of those participants gave birth to preterm babies who were underweight or died. Next slide. So what's next? Next slide, please. NICHD published a strategic plan in 2019. In it, maternal health is prioritized, inclusive of both health disparities and prevention medicine. The same year, NICHD convened 2 workshops, one a future directions meeting, and the other a community engagement forum to inform a maternal health research agenda. Racism was a theme that resounded throughout both workshops regarding research clinical gaps and policy opportunities. Next slide, please. The GRAVIT study, Gestational Research Assessments for COVID-19, supports an analysis of medical records of up to 24,000 people within NICHD's maternal fetal medicine units networks to examine maternal and neonatal outcomes for pregnant people with and without SARS-CoV-2 infection. Findings have shown that pregnant people were at higher risk of severe disease, including hospitalization, need for ICU care, and medical ventilation with COVID-19. Next slide, please. NIH is currently leading an ASPE-funded data infrastructure project to develop an HL7 FHIR implementation guide for data linkages between multiple maternal electronic health records and with infant electronic health records and vital records. The goal is that this will be used in research on pregnancy, pregnancy outcomes, and pregnancy-related conditions, comorbidities, and procedures. Next slide, please. The Implementing a Maternal Health and Pregnancy Outcomes Vision for Everyone, or IMPROVE initiative, supports research to reduce preventable causes of maternal death and improve health for birthing people before, during, and after delivery. Under IMPROVE, approximately $7.2 million in grants were awarded through a Notice of Special Interest on Maternal Mortality. Notably, research to resolve health disparities and attain equity in maternal health was a critical goal of this NOCI. Applications to a second NOCI are currently under review. Next slide, please. In fiscal year 2020, the National Institute of Minority Health and Health Disparities led a funding opportunity announcement entitled Addressing Racial Disparities in Maternal Mortality and Morbidity. Awards were made to 6 institutions and are expected to total over $20 million over a 5-year period. Also in 2020, NIH Centers for Excellence on Environmental Health Disparities Research supported 2 centers with foci on maternal health: the Maternal and Infant Environmental Health Riskscape Research Center at Baylor Medical College and the Maternal and Developmental Risk for Environmental and Social Stressors Center for Environmental Health Disparities at the University of Southern California. While both will engage the community and researchers using interdisciplinary collaborations to understand the contributions and cumulative effects of exposures in the biological, physical, social, and built environments during and after pregnancy on maternal and infant health outcomes. Next slide. We're excited about the work currently being done and looking forward to the work we expect to see in the pipeline. In order for us to substantially move the needle in reducing and eventually eliminating racial disparities in maternal morbidity and mortality and racial disparities in health more broadly, it is critical for us to understand the impact of institutional policies and structural barriers, inclusive of racism and health.
Thank you, Juanita. We really, really appreciate you sharing what's going on at NIH. It's very exciting to see the kinds of investments that are taking place.